Computer. Et voilà. Je veux juste checker qu'on... Ouais, voilà, parfait. Donc, un peu juste au sujet de nous.
Just a little bit about us. Community of practice. The funding comes from PUDs or SUAP, which is a program on use and addictions of substances from Health Canada. So we also have a collaboration with the London Inter-Community Health Center. It's the Canadian Association of People who are consuming drugs, and also for the Alliance for Healthier Communities. And it's the collaboration between all three. Our objective is to support the scale up of supply programs that are safer for the strengthening of the capacities and the exchange of information. Our priority is also to organize medical models so that we may have safer supplies, and so that we also want to reduce the errors and of damages done and also for public health question. And we also want to support mobilization so that we have non-medical models and also purchasing co-ops and decriminalization. Also, we have many resources to offer you. My colleagues are going to give you the links. So we have events, we have exchange workshops, knowledge exchange workshops, we have the development of tools and of, counsel, like of tips. We also have exchanges or discussions on community and interest groups. We also have mentorship and also support for prescriptors and programs. We also have a certificate of attendance. If you ever need a certificate of your attendance here, we're going to give you a link at the end of this webinar. So it's going to be done automatically. So you just put your email and your name, and it's going to give you 2 certificates. The first one is in English and the second one is in French.
Donc, 2 petits plugs.
So 2 little plugs.
Désolée, j'ai pas eu la chance de faire
I'm sorry, I was not able to translate this slide, but
la recherche émergente sur
it will be the emerging evidence on safer supply. It's a new webinar.
Lundi de chaque mois.
It's going to happen the first Monday of every month.
Webinaire débutante ce lundi, le 3 octobre.
So we have the first one this Monday, October 3rd.
Dr. Gillian Cola, Dr. Gillian Gomez, puis Ashley Smoke, les powerhouses d'approvisionnement.
And all the powerhouses of the supply that are going to come and speak to us.
Venez nous rejoindre. Je pense aussi, ma collègue va dropper le lien pour ça.
And please join us. My colleague is going to drop the link for that as well.
On a plusieurs ressources et maintenant on a plusieurs traductions.
So we have various resources and we have a lot of documents that are translated into French as well. So if you want to access our networks in French, just please do it. And all the networks are almost there. All the information, I'm sorry, for the resources are there. The interpreter apologizes.
Donc, ça fait la job pour mon petit PowerPoint, mon petit bienvenue.
My little PowerPoint did its job.
Donc, je pense qu'on est tout le monde dans la salle. Je pense on a censé avoir Alexandra de Q8, mais ça se peut qu'elle
in the room. I
se présente pas.
think Alexandra is not here yet. Maybe she's very busy today, but maybe she's not able to join us, and that's okay too.
Donc, ça me donne beaucoup plaisir de
so it's giving me a lot of pleasure
to biographies qu'on a préparées avant. Je vais liser tout ça. Peut-être faire un petit allô aux caméras.
Maybe you want to say hello
on a
in the cameras. We have
Marie-Ève Goyer,
Dr. Marie-Ève Goyer.
Médecin prescripteur de l'approvisionnement plus sécuritaire.
She's a prescription doctor for a safer supply.
She's a médecine familiale et médecin d'urgence.
So she's a prescribing physician, but she's also a clinical associate professor, Department of Family Medicine and Emergency Medicine at the Université de Montréal. She is scientific director of the clinical and organizational support team in addiction and homelessness. This is with the IEUD in Montreal. And also, she's also the assistant head of specific programs of the CIUSSS of Centre Sud de l'Île de Montréal. And I will also present Marie-Christine. Hello, it's the first time that we're meeting also. She has almost 10 years of experience in homelessness addiction in the Montreal Community Network as a street worker and intervener with parents of children aged 0 to 5 years that have a TUO. She has a bachelor's degree in social work and a master's degree in addiction intervention. She has 3 years of experience as a social worker and professional coordinator at the CIUSSS Relais clinic in the south central part of the island of Montreal. So it's a little bit like she's working with Marie-Ève Goyer. And so welcome. The next one, the beautiful Isabel Forte. She's Quebec regional representative of Moms Stop the Harm. She's also a member of the board of directors of Dopamine. It's one of my old jobs here in Montreal. She's also a mother who lost her daughter to an overdose at the age of 24 and who suffered from a substance use disorder as well as mental health problems. So we're very, we recognize your big loss. And we're not lucky, but we're happy that you are here to share your perspectives. And the last one is Jérôme, who's eating a little bit. That's okay. Jérôme Benedetti is an expert consultant and a speaker. He's an advocate for a non-prohibitionist drug legislation and that does not stigmatize its users. So welcome, Jérôme. We also have the beautiful Vincent de Maisonneuve in the offices of Équipe Sud. He's a project manager for the Quebec Association for the Promotion of the Health of People Who Use Drugs. So this is the biggest association of people who use drugs. So Vincent works as a project manager for the development of new prevention and harm reduction tools at Équipe Sud, an organization by and for people who use drugs, as I said before. And the last but not least is Simon Vermett. He's harm reduction worker and addiction counselor with the SAPSA, which is Solidarity Cooperative and Interzone, I think, graduate in economics and agri-food management for Laval University, and psychosocial counselor for the SAPSA Solidarity Cooperative in Quebec City. He's member. He's also member of Équipe Sud and ADIC and member of the drug user community. And he's advocate for major reforms in drug policies in order to bring them in line with the 17 United Nations Sustainable Development Goals. So welcome, Simon, and welcome everyone. And that's how we're going to launch our event. So it's going to be certainly me that's going to moderate. So we're going to ask the first question. The first question, actually, we have 3 prepared questions. After that, we're going to do a little Zoom poll. And then we're going to start with the questions coming from the public, from the audience. So question number 1, what is the context in Quebec for safer procurement or supply? So we're going to ask that Marianne will begin with a little context for Quebec, maybe. And Jérôme, if you have something to add, please don't hesitate. So the mic is yours. Well, hello to everyone. Thank you for the invitation. Thank you, Alex, to have organized this. I speak very fast, so if you want to slow me down, I don't see the interpretation. So if you're seeing that the interpreter is dying, so please let me know and I will try to slow down. I will try to make stop, but it's not natural at all for me to do so. I think, first of all, we have to situate the definition of safer supply and to understand that this definition is evolving. So I will give you mine. That is not exactly the one from CAPUD either, and that's okay. When we're talking about safer supply, me as a physician, I'm talking about replacing any substance that is bought on the illegal market, so that I can have a content that is prescribed, that is dependable, that it will always be the same content. So the person who's going to be using it, and they will know exactly what to expect. So that's the first thing. Secondly, when I'm prescribing the safer supply, my objective is not one of treatment, but rather of public health. That is, when I'm doing this, what I'm trying to do more than anything is that the person does not die based on a contamination of the substance. And we want to also reduce all the other negative consequences. So we will talk about this later. It's fundamentally a problem, whether it is for a physician or teams that were trained to do treatment, to deprogram ourselves so that we can try to have an approach that is more public health centered. And it has also an impact on accessibility, because to get prescriptions from a doctor is not obvious. And that's one of the issues, but we'll talk about it later. So to give you a little bit of a history in Quebec and where we come from, those who prescribe methadone, PAO, opioid agonist therapy, we all did a supply that was safer for the long time, because some patients asked for it when it didn't work. And we often call this a TAO in French. That's alternative. Okay, so it's OAT. Thank you for that, Rebecca.
Naloxone ou après ça de la morphine 24 heures du Cadien. Mais
various drugs like morphine or we were not backed by any guidelines. We didn't talk about it. And we did all this, alone, individually in our teams with a lot of different levels of comfort. And we started before COVID that something's happening on the illegal market, that we never seen this before. And I'm a practicing physician since 2005. And I would say that it's been 5 years already that there's something wrong. Our patients they spoke a lot about effects that they've never had before. We saw a lot of overdose. We also saw the tolerance to opioids of our patients that increased. When I started in 2005, when I gave 200 milligrams of methadone, I was super nervous. It was funky. It was rare. And no one needed 200 milligrams. Now I give 2,000, 3,000, 4,000 milligrams. It's regular. It's, our needs of our patients to be comfortable, it has really changed. Even before COVID, we can see there was an alarm, there was alarming trends, but now we decided to prescribe. We wanted to make sure that the safer supply in Quebec started with Dilautide, Domorphone at short action, and the interpreter thinks 400 milligrams. So we started with that. So when people came to see us, and we knew very well that what we're going to prescribe will be not sufficient, we started with a treatment with methadone and Dilaudid. And when a person had enough dose of Suboxone, for example, we would gradually take down or not of the safer supply of Dilaudid and focus on the treatment molecule. And then COVID happened. And with everything you know, there was a stopping of access to the health network, a closing of the borders, a big change on the illegal market. And this somewhere gave us a little bit of a legitimized way to develop this practice with fewer obstacles, whether they are legislative or organizational. And so then we really started doing prescribing Dilaudid and hydromorphone pretty frequently. And we were increasing quantities. Before we were a little bit hesitant. We didn't have any guidelines on which we would depend on medically and legally. And then we had the BC had the first guidelines, then Quebec had a COVID guideline, then CRISM, which was a Canadian organization. And then we started doing more, or a bit more, and then we had to give doses that were to take home, and because they couldn't come to pharmacy. So this practice really exploded, including the arrival in Quebec of the first treatment that was injectable, that was hydromorphone, that was injectable, I think in April 2021. It's been a year ago, which is a program that has a very small number where we can give very big doses of injectable drug. It's a treatment, so it's not necessarily safe for supply. But also the thought on what we're going to do with the other molecules. I'm going to bring to your attention that everywhere in Canada, safer supply is especially for opioids. But it's not only opioids that we buy on the legal market. So it's not only those that are contaminated. So as clinicians, we are wondering, should we not replace cocaine, stimulants, benzo products, etc., etc. So the reflection, the thoughts about this is ongoing. And to end my intro on where we're coming from, Quebec is in a practice that has not been officially, approved by the different orders, whether it's for doctors or nurses. We're doing prescribing, whether a nurse practitioner or us. We are in a outside of norm type of practice. So doctors are not always feeling at ease. It's a very niche type of practice. And so there are real issues of accessibility in Quebec everywhere, especially outside of the big cities. People are not, they don't know that it exists and they might not have access. And also the practices are very different. Some doctors are prescribing a lot, some doctors prescribe less, because it's a practice that has not been very studied. So everybody is a little bit afraid right now, but it's mainly it's a practice that is mainly with the practice. So we're very far of reaching the public health guidelines. So which their guidelines says to, take people away from the illegal market. And right now we're talking about replacing fentanyl, for example, and other very strong drugs with Dilaudid, which are usually not sufficient to reach the complete tolerance of the person, and really to take it away completely from the illicit market, because that would be the objective, to help the person get out of that market. Marie-Ève, there's already a question for you. I have placed the translation in the chat, so I'm going to ask it in French. How did you get the authorization to put in place a practice that's so innovative? And have you met difficulties when we're trying to face the philosophy of reduction the effects, negative effects, rather than eliminate this? Do you want me to answer the question now? It's a big question.
En fait, je tourne ma langue dans ma bouche. Comme médecin, on a toujours le droit.
Actually, as doctors, we always allow to go outside of the guidelines if we're capable of justify the rationale in our file. So we have practice, guidelines that tell us what we should do, but we can always leave them if we can justify it well. And to tolerate the discomfort that if there's our investigation, we feel that it's sufficiently justified what I'm writing, that I will not have any problems. So this is where the problem is. The tolerance to discomfort is very different from one person to the next. But to tell you, the strategy that we've used in Quebec, we've made the choice as we've written the guidelines, and I put it in chat of safe supply COVID in Quebec. So we presented it to the other medical professionals so that we were sure that we would not have any problems, and also to reassure our colleagues. But also we had good literature from BC and from Ontario. So we, were supported by certain things, and also the issue of COVID. So there was a emergency created by COVID because we wanted people to stay isolated. And then we put in place a Francophone community of practice to make sure that we can help people in their practice. So I think that this is a little bit of the reasoning. In terms of the, when you say embracing harm reduction philosophy instead of one of abstinence, this is the eternal question that has always existed. Now that I'm older, now when we tried to distribute syringes, it was the same thing. Oh, now you're contributing. People will inject themselves more. When we wanted to have services, well, now you're contributing. We shouldn't do that. When we wanted to put in place a treatment that's injectable, it was the same thing. But Quebec was ready for that. It has been years that we were working with public health colleagues to show these effects. This reduction of harm is evidence-based. So we have a lot of data on this. And clinicians that have endorsed, this method were ready for that. And so some colleagues that were in the community of practice, and I'm saying hello to them because they're here today. And also we saw the experience of users, and this made everything evolve. Jérôme, I see that your hand is lifted. You can unmute and go ahead. I have a question for you, Marie-Ève, and for everybody, actually. You're saying people are afraid and doctors are a little bit afraid. They're shy. We understand this is the eternal question. I heard saying that I can't be the first one to do it, but somebody is needed to start, the ball rolling. So what can we do concretely to develop the situation or to help with the situation? Because right now, what I'm noticing, we had the opioid overdoses, then COVID happened after. This allowed to open. There's been an opening on many things opened up because of this, and now we're seeing the interpreter cannot hear properly. The sound is not clear enough. So I lost myself a little bit in my thoughts, but I just wanted to make a point. How come doctors are a little shy to prescribe those types of substances? That's also a big question. Of course, I don't have all the answers, and I'm thinking that my colleagues will definitely give their own 2 cents. But what I would like to add right now is that the stigma that the people who are using drugs, they find themselves everywhere in the society. Right now, apart from Université de Montréal, where we forced for years to having training for addictions to every doctor, but in other schools, you cannot, are not trained to, and will not know how to manage a prescription for an illegal drug. So in most of emergencies and hospitals, you will leave without treatment and without melanoxone kit. So if you're in a diabetes crisis, for example, they won't just see what's going on and then let you go outside. No, they're going to prescribe things. They're going to there's going to be follow-up with you. So the doctors are translating the societal stigma that it's not that important as a competency, and it's okay to not take to treat someone's drug dependence. But if you don't take care of someone's a heart attack, you would rather way be thrown out, you would lose your license. Okay, Marie-Christine, I think it's your turn. Hello to everyone. Well, Jérôme, to add a little bit of information on this, I'm inviting all the teams that are working on addictions. We've asked ourselves a lot of questions on safer supply, and we decided to get a counselor on. The interpreter apologizes. There's too much echo in the sound to speak at the same time. So should we do, is safer supply a good idea? Are we doing, are worsening situations or bettering the people's situations? So this is
juste les médecins, mais ont quand même ce souci-là aussi
not other professionals worry about this. We have the security of our patients, as a first concern. In terms of safety, I would add, we want to avoid overdoses. I think that where we feel bad is if safer supply is sold to bought fentanyl, a substance that is even stronger, or a substance that is causing overdoses, that's why we feel bad. So I invite everyone to make this ethical exercise with their teams. I don't know if it was Vincent or Simon or Marie-Ève or Jérôme might want to answer this comment before. I just wanted to add what you said, Marie-Christine. It's right away, it makes me think about something. People that are selling their stuff to buy something else, why don't we give them that other thing right away rather than go through the 50 substances? Sound problem. There's a lot of problems linked to the fact that some people are taking their medications and then they're going to sell it to buy something else. So we have to prescribe what people will take. So that's what safer supply is. So we won't do that. But for me, my definition of safer supply is that in Quebec, for me, there isn't any. Apart from when some doctors prescribe the substances that the person wishes to have. I think that we have it. And I see some that do this job here, these substances that do prescribe these substances, sorry. But that's my opinion on the matter. I think it was Vincent as well. Oh, yes, yes. Can you hear me well? Yes, yes. If we continue on the same subject a little bit, it's true. Oftentimes we're talking about safer supply. We often talk about opioids because the overdose crises, oftentimes we think opioids are to blame, but if we're looking at the coronary office, we'll see that it's not often true. So other drugs are also present, and there's a lot of dangerous drugs mixed with benzos. Before, heroin with fentanyl, and now it's fentanyl cut with benzo. It's not a great mix, but it's very dangerous. So that could happen. So we're often thinking about opioids. People, those who are addicted to opioids, they look even worse because they're a little bit dependent. But it's not like I no. But when we're talking about cocaine, I don't want to get Ritalin. I want to get better quality cocaine. So that's an example. I think at BC, and it changed, but I think the Ritalin. Otherwise, I'm changing subjects a little bit. But before we talk about stigmas in terms of doctors, I filed that some will go up. It goes above the question of overdoses. I had a friend that worked in Abitibi, and he said that it doesn't make any sense. I'm speaking fast. I'm sorry, but I can't get that here this hospital, so I'm going to go to a hospital in Montreal. So in rural regions, I think there's a lot of work to be done, especially in Quebec. It's a small place. It's a big territory, but not a lot of people. So urban communities, that's one thing, but semi-urban or rural regions, that's very different. And we're not where we are supposed to be, where we should be. For now, I'm finished. I wanted to go back a little bit on the question of factors that people can benefit from a safer supply, and they're going to resell this safe one because they want to have a bigger prescription that they need, and for whatever reason they want something else. I'm thinking if everybody had access to their prescription, to their safer supply, it would actually sink. Okay, if everybody has their own safe supply, then they don't need that there would no longer be a market for reselling, their drugs. I remember at a time when I came to a doctor's office, and I said how much I would consume opioids, and it wasn't that big when we're comparing what's happening now. But when we would come with the office, the doctors, they didn't believe me because in their literature they learned that other ones were mortal, mortal doses, and so I know that it was in the 2005, 2006. So I'm wondering if now in the doctors' courses, are they now more in tune with the tolerances? Maybe I should ask the question to Marie-Ève or Marie-Christine. And Isabel, I will let you speak. The answer is no. And with all humility, when we started our product, when we started our program of injectables, relay injectables, the first person that started was not a big consumer. We gave him the first injections of iodide intravenous form, and we were all around him, all sweating, and we were all afraid, and we gave him. He went up on to go almost the maximal doses, and he was not a big consumer. He was sedated, and I was here ready to. And so I said, oh no, it's worse than what I thought. I knew it. I was in, in a community where that explaining to me every day, and I see it. And I thought that I had this conscience of a very big tolerance. And even though I was far from seeing, so certainly to get back to what Vincent was saying, the poor consumer that's trying to go to the hospital for any reason, and he would give him a little bit of Tylenol and Dilodid 1 milligram, and then and now that when I give the training, do you understand that I have some users that have 2,000 of Cadian, Canadian doctors and nurses would call us. I think you put too many zeros, 1 0 too many in your prescription. No, it was really 2,000. No, 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 we're not going to give that much. So when I'm giving the training, I give them, do you understand that I have some patients that have 2,000 of Cadian and 2 injections of hydromorphone, 200 intravenously per day, and are still not at ease. So if your patients say that they have pain, well, you have leeway. But after that, because we talk a lot about physicians, and maybe I'm going too fast in the issues that you'll tell me, Alex. But for me, that's what the issue is of the safer supply. It does not have to go through doctors. It is not a medical question. If it is a doctor, it's maybe because we are already in treatment. Now we're on a sideline. We don't even have enough doctors and prescribers for all the persons that need or want a treatment. And for all those doctors, not everybody is trained, and it's an innovative practice, and we will not arrive at our goals. So we have to think outside of the box, because we won't, achieve our goal with only the doctors. We have no choice but to go through this method, fair enough. But I think that the main issue is, well, until we say that the doctors don't do enough, yes, it's true what you said. We have to do work to get more flexible. But even if all the doctors were completely willing, it's a question of public policy. It's a question of legalization, decriminalization, and we have to see then what? How are we going to get this out of the medical field? It's not mine to judge whether your consumption is good or not, if I'm at ease or not. And I think that this was where we're at right now. Isabel, I'm going to allow you to speak. I think that Marie-Ève really summarized exactly what I was going to say. That's what safe supply is. It starts at every level. And it should not go through a medical act. And this is at the heart of the problem. I come back from Brussels on the summit on Francophone summit on addictions. And somebody talked about the concept of sustainable human development. And so it's important to bring back the person who's consuming drugs. So now our overdoses are happening with people who are using drugs that don't know what they're using, but also with people who are doing it on a recreational basis. And now we really have to think about all these people. And we also spoke about the question of accessibility at the health, center. And can also do a parallel with what happened with with the young Amélie Champagne a few weeks ago, because she was in psychiatric treatments, she wasn't seen in an adequate way.
De juger son problème et finalement, elle s'est suicidée. c'est un peu la même chose qu'on voit dans le système avec une
Finally,
personne
she committed suicide because she was not well treated right away, nor well considered.
se sent trop stigmatisée, trop jugée et qu'elle ne recevra pas de toute façon le soin dont elle a besoin. Donc, on se ramasse avec des morts sur la conscience. Et je peux vous dire de façon très personnelle, c'est arrivé avec ma fille d'être à l'urgence et de dire, ben là, elle a un problème de consommation, qu'elle revienne quand elle aura dealé avec son problème de consommation, on la traitera en psycho après. Ben, les choses ont évolué vers, c'est ça, Vincent dit, c'est en plein ça, les choses ont évolué vers le fait qu'elle n'a pas été prise en charge et qu'on lui a prescrit des benzodiazépines, qu'elle a été mal évaluée en psychiatrie, entre autres, et finalement qu'elle a été échanger ces benzos pour quelque chose de plus fort sur la rue. Elle est le cas parfait, dans le fond, de quelqu'un qui n'a pas été pris en charge de façon adéquate et qui est tombé dans les mailles du filet, dans le fond, du système, qui a consommé une substance qui était contaminée et qui en est morte. Donc, elle est morte par la stigmatisation et des mauvaises politiques. Et ça, c'est toujours le discours, dans le fond, que je tiens. Et c'est pour ça que je dis qu'il faut ramener l'individu qui consomme au cœur même des préoccupations, que ce soit nos politiques, nos changements politiques, et la décriminalisation est un des premiers pas. Mais il faut vraiment voir dans tout l'ensemble le spectre de l'individu comme tel. C'est complexe, la dépendance. On ne peut pas comme one size fits all. Il faut, je pense, qu'on prenne vraiment comme un paquet de monde dans différents domaines qui vont aider cette personne-là. Et c'est ce qui ne se fait pas présentement. Puis, je ne pense pas que le problème va se régler demain, du moins pas avec le système qui est défectueux, le système de santé qui est défectueux présentement. Et moi, je lève mon chapeau au docteur Goyer, à Marie-Christine, et tous ces gens qui œuvrent dans le milieu, qui font justement la différence, qui essaient d'être rogue, comme on dit en anglais, hein, c'est you go rogue, donc tu fais un peu les affaires en dehors du cadre, mais tu as l'intérêt de la personne, les intérêts de l'individu au cœur de ton traitement. Puis c'est ça qu'il faut. Fait que chapeau, continuez. J'espère qu'on va vous donner plus de latitude, plus de ressources pour pouvoir poursuivre le travail parce que il est essentiel, votre travail. Donc, c'était ma petite intervention in a nutshell. Je vais laisser la place aux autres maintenant.
Merci Isabelle, je veux juste interpeller un peu. Je pense qu'on a eu un problème de connexion pour un de nos interprètes. Donc, pour les anglophones dans la salle, on travaille bien fort pour qu'elles se rendent dans la salle. So sorry everybody, I'm just going to switch to the English for 1 sec. Sorry, folks, we've just had a connection issue. One of the Zoom connections dropped for one of our interpreters. So we're working our best to try to get them reconnected. So just stick on that English channel and it should come back really soon. Donc, Simon ou Jérôme ou Vincent, je ne sais pas c'est qui a levé la main avant, mais si un de vous veut peut-être prendre les commentaires d'Isabelle ou peut-être poser une autre question, c'est à vous.
Oui, ben, je vais y aller vite. C'est ça, c'est moi, je me rappelle, parce que moi aussi, avec le temps, du fait que j'ai travaillé à la clinique SPA, j'ai travaillé avec des médecins, des infirmiers, infirmières. Maintenant, je suis à la clinique SAPSA, qui est une clinique infirmière, donc je travaille vraiment intimement avec la réalité là, des prescripteurs. Là. Puis je me rappellerai toujours là, le premier safe qu'Isabelle Tétu, ma collègue, c'est quelqu'un qui a eu beaucoup d'importance dans ma vie, qui est celle qui m'a prescrit mon programme de méthadone en 2009, etc. C'est vraiment quelqu'un que j'admire beaucoup. La première fois qu'elle a prescrit son self-supply à un gars, je me rappelle, je suis allé y acheter un bouquet de fleurs puis un petit euphorbe, là, c'est vraiment gros. Puis je voyais à quel point elle avait été nerveuse, tu sais, puis pour ça, c'est vrai que je suis chanceux d'avoir pu être témoin là, de cette pression-là qu'elle a ressentie. Puis puis pas qu'elle ne veut pas essayer de faire les choses, mais premièrement, en tant qu'infirmière praticienne, elle n'est même pas médecin. Là, vous êtes obligé de se baquer avec un médecin au CRDQ en plus. Fait que, c'est vrai qu'il y a une grande pression là-dessus. Fait que, c'est vrai, je remercie, je vais saluer le travail, mais effectivement, si on est rendu à militer pour la légalisation puis un autre modèle, ben c'est ça, on va avoir besoin de l'appui des professionnels. C'est sûr que moi, j'aimerais ça avoir la crédibilité suffisante en tant qu'usager, en tant qu'expert de véhicule. J'aimerais ça que ma parole suffise pour être entendue, mais bon, on va aller chercher toute l'aide et tout l'appui des gens là, qui ont une crédibilité professionnelle là, qui peut nous aider là, à aller chercher nos libertés.
Vincent, je te laisse la parole.
Préfères-tu que je parle en anglais s'il n'y a pas d'interprète? Non? Oui, non? OK. Bon, ben.
C'est en français parce que je pense que l'interprète va prendre le relais à l'autre côté.
OK. C'est bon. Il y a comme plusieurs choses qui ont stimulé un petit peu mon intérêt là, dans les dernières conversations. On parlait que justement qu'on aimerait ça que la source du safe supply ne soit pas médicalisée. Puis là, c'est une question ouverte parce qu'après ça, la question, c'est quelle serait la source du safe supply, sur quel modèle pourrait-on distribuer du safe supply, comment pourrions-nous nous fournir, justement, parce que des fois, on peut se dire, bon, on aimerait ça ouvrir des coopératives d'usagers. Puis là, les coopératives d'usagers, c'est sûr, il y a des documents qui ont été écrits, justement, il y en a un par le BCCSU, ou en tout cas BCSSU, je pense que c'est BCCSU, par rapport à des coopératives, mais encore là, ça soulève des questions comme qui a accès? Est-ce que c'est juste les consommateurs et consommatrices de longue date qui ont accès à avoir le bon stock pur, puis si tu ne fais pas preuve que tu es un consommateur de longue date, tu as juste accès à aller acheter du stock sur le marché noir qui est contaminé. Puis après ça, ben justement, comme c'est sûr que on peut bien dire, ben, on aimerait ça avoir du safe supply, mais qui pourrait fournir les substances parce que c'est pas nécessairement légal partout, etc. Est-ce que le Canada pourrait se permettre de devenir un producteur géant de pavots? Bon, enfin. Donc, c'est plusieurs questions que j'aimerais me poser. Ceci dit, c'est sûr que il y a plein de manières de voir les choses. Moi, c'est sûr que à mes yeux, l'important, c'est qu'il y ait le maximum de substances disponibles le plus rapidement possible pour régler un problème qui existe maintenant. Fait que si on peut faire avec le moment où c'est malheureusement médicalisé et pharmaceutique, en tout cas, bref, issu du milieu pharmaceutique, c'est sûr qu'on va le prendre pareil là, parce que la solution a besoin d'être implantée hier. C'est ça. Puis là, il y avait comme une question je ne sais pas si on voulait y répondre tout de suite là, dans le chat, mais c'était une bonne question. Ouais, je ne suis pas un expert, là, mais dans le fond, comment que je perçois la question, c'est are most people in Quebec receiving their self-supply to use in the community? Si j'ai bien compris, la plupart des gens, quand ils ont commencé à recevoir leur self-supply, il fallait qu'ils l'aillent à chaque jour. Là, je ne sais pas si c'est encore le cas, s'ils ont des doses à garder, mais il me semble que ce n'est pas tant le cas. Non, le safe supply, non, les gens ne sont pas required d'utiliser leur safe supply dans des sites de consommation supervisés. Et heureusement, parce qu'il n'y en a pas beaucoup des sites de consommation supervisés. Notamment à Montréal, on a encore comme enjeu qu'il y a juste l'injection qui est acceptée. Il n'y a pas d'infrastructure, en tout cas, bref, d'infrastructure pour l'inhalation ou autre méthode de consommation qui pourrait en réalité réduire les méfaits parce que c'est peut-être un petit peu moins dangereux de consommer autrement que simplement par injection. Parfois, peut-être pas tout le temps. Peut-être que je peux repasser le flambeau à la question que j'essaie de répondre moyennement adéquatement. Là.
Merci Vincent. Je vois le main de Jérôme. Ça se peut que tu veux prendre la parole à propos de ça.
Je me suis un peu perdu, là. J'ai un peu oublié le truc sur lequel je voulais rebondir, mais juste pour dire que l'histoire se répète éternellement. Hein, on a du mal à mettre en place du safer supply avec des substances machin. Vincent, tu disais ça va être pour certaines personnes, mais à l'époque avec la méthadone ou alors en Europe avec les premières prescriptions qu'il y a eu en Suisse par exemple d'héroïne médicale et tout ça, c'était il fallait que tu sois le pire des junkies irrécupérables pour y avoir droit, tu sais. Puis après, au fur et à mesure que le temps y passe, les critères, on les abaisse tranquillement pour... mais putain, on peut-tu comme se dire, merde, on le sait, tout ça, qu'est-ce qu'on fout là, bordel? C'est quoi, c'est qui bloque là? Je sais que c'est politique, je sais que c'est philosophique, tout ça, mais bordel de merde, les gens crèvent. Où les gens ont plus de vie, tu sais, quand je dis les gens ont plus de vie, je parle de moi, hein, mais tu sais, comme tout ça parce que je peux pas avoir accès à des trucs. Et puis on parle de santé, mais il n'y a pas que la santé non plus. Il faut oublier tout l'aspect social, financier, etc. Tu sais, mais moi, des fois, je braille tellement ça me fout en l'air de voir à quel point, tu sais, qu'est-ce que j'aurais pu être, qu'est-ce que j'aurais pu faire dans la vie, tu sais, si j'avais pas foutu tout mon fucking fric dans la dope, tu sais, si j'avais pu avoir à disposition les substances que j'avais envie de prendre, tu sais, qu'est-ce que j'aurais pu faire, c'est comme avec cet argent-là, après c'est comme je veux pas jouer les victimes non plus, hein, mais c'est ça, c'est comme ouais. Le mec pas prétentieux du tout. Combien d'Einstein sont passés dans un local à poubelle avec une seringue dans les bras morts parce qu'il n'y avait pas de... En tout cas, bref. Je pense que vous m'avez compris.
J'ai l'impression que Simon a une réponse à ça. On t'entend plus.
Oui, allô?
Voilà.
Oh, correct, oui. En fait, ouais, j'ai une réponse. J'ai pas de réponse, mais en tout cas, c'est parce qu'on parlait, on rêve, puis je ne sais pas si on est rendu là, puis je sais qu'à un moment donné, ça pourrait être pertinent, mais moi, je m'imagine tellement, puis c'est peut-être ma déformation d'être ancien agroéconomiste, là, mais de voir une filière intégrée avec des producteurs du Sud, par exemple, qui se constituent en coopérative, eux autres aussi, puis avec des filières de transformation, puis de réinsertion sociale à travers tous les rôles de cette filière-là, tous les jobs qui pourraient se créer dans une filière intégrée, là, puis mais c'est ça, j'ai le droit à mon utopie aussi, là, mais je voulais juste partager ça, c'est qu'il y aurait tellement, je pense que sky's the limit dans ce dossier-là, là, si on se donnait la chance d'arrêter de s'inhiber, là, puis que le dossier, puis c'est ça, je pense qu'on avait parlé en préparation aussi à quel point, justement, c'est un dossier qui est politique. Il y a des gens qui ont des opinions, qui ont un pouvoir sur nos vies, sur nos choix de vie, juste parce que, tu sais, je ne veux pas faire la critique de la démocratie. Certainement que la démocratie sera certainement quelque chose de beau, mais tu sais, j'imagine, je ne sais pas si on était dans un despotisme éclairé, là, où on va dire, OK, on va de l'avant, là, tu sais, sans se soucier là, de la vie, de l'opinion de certaines personnes, tu sais, qui ont juste une opinion, là, qui n'ont pas de savoir, là. En tout cas, je ne veux pas non plus commencer à me craquer trop, là. On va rester dans le positif, mais ouais.
Marie-Ève?
Moi aussi, ça va paraître bizarre.
Marie-Ève, this is going to be strange, and you may ignore. The technical point now for the questions, if you want to see the state of the practice in Quebec with the community of practice, we did another survey now. With all the different types of substances that have been prescribed. I would like to flag 2 points coming out of the survey that may be interesting. First is most people have those to carry away with them, and most prescribers are afraid of diversion prior to the prescription. But when we ask them about the diversion, They do not feel that there's so many of them, in fact. So this is a point. I want to let you know, to follow up on what Simon just said, is that the question I'm obsessed with is how can we do as doctors, as teams, and as society indeed, to be together in this. This is what we have not succeeded to do. I seize the occasion because we're 80 people together, all people advocating for the rights of consumers, to launch this question. There's a real gap. There's you, patient, me, doctor, I know better than you what is good for you, and this is what we're going to do. There's me, the citizen, and there's you, the quidam, consumer. What is happening to you is not my issue. How are we going to do a match because of the gap? And there was the COVID as well, and the H1N1. Why, when these viruses are around, we do everything that is possible. We create new digital system. We bring everybody on board, all the doctors, everybody, and it could happen to me also. So we need to do something, but opioids and stuff, it does not concern me. So it's not that of an issue. It is a big question, but I think that the nerve to touch is there. As long as we cannot provide a response to this question, we are going to end up in traps, in gaps. Just to add to the complexity of this issue, we all are so upset to see people die all the time, that when we meet people who do not understand the issue, I chat, I rant, because I'm not capable anymore, and I obtain an opposite effect. There's a boycott, there's a big political games we need to ponder about. I just suggest this question to you without having an answer to it, but maybe there are some groups who can chat and make sure that there's pressure, though it obviously doesn't work as well as we would like. I can respond to this, at least in part. We do meet in person. And I've asked them recently, that was only 3 weeks ago, I asked the question to a Liberal MP at the federal. We want the Emergency Act to be adopted for this. Now it doesn't work because it was with our government who used the Emergencies Act because of the health condition. But now with the parliament, we cannot. Now we cannot take the risk to use this Emergencies Act again. But when we talk about that all the people are dying, maybe you don't understand that. And we have an answer, well, we cannot do this. We prefer to do the measures with the Bill C5, for example. We're going to do it step by step, doing things very well, slowly. But in the meantime, people are dying. So the data that are coming out of Quebec, it's an issue, inaudible. Now there's more elections. We're not talking about the issue. People keep dying. And the more we talk, the less results we have. Maybe we have a small asset as parents, is that we are going to touch on the sensitive string people have in them. As for me, it is to really touch that sensitive nerve in the largest amount of people. I want to explain to people that my daughter was a student in university in international law. She was advocating, she was working really hard. She had never lacked of anything. It can happen to you. It can happen in your family. And the more we are sharing these stories, the more we are going to touch people's hearts. This stigma, bringing awareness, unfortunately, so many deaths. We're not talking just about the homeless people living in the streets with all the little stigmatizing language that is being used in such case. We must change the language we use. We must bring awareness and share the fact that it can touch anybody. We can also share all the death, people who consume by themselves on their own in the suburbs. There's too much stigma. I do my best to reach out to parents who have dead children. They do not want to know anything. They do not want to talk about it. They're afraid to be judged. It's if someone next of kin or someone close to them dies of an overdose, they go through this double stigma as parents and living, grieving the person who died. I do not think we can have an answer, though we cannot keep just talking about, we must keep talking about individual stories. My daughter, if some things were different, what could I have done? What could have my daughter become? She probably would have become one of the advocates here around the table. If she was still alive, for sure she would have done that. We must speak about these people and all this wealth we pride ourselves from, all these beautiful souls we lost because we do not care about their life. Every single life does count, and every single life that is lost has a domino effect on the families. These people are lost. They will not be found back. Sure, we need to talk to the right people, but we also need to bring tears to their eyes. Otherwise, I think this is the only way we can make advances, is by having people cry. Unfortunately, it is so. I keep pushing and I do my best to bring awareness to people and trying to touch as many as I can for a change to arrive. Unfortunately, change is not coming fast enough. It's an emergency. People keep dying. And there's all of us here around the table. If I may, what you just said really touches me. You're a Mother Courage, as we call them. Congratulations to you. What really brings me upside down is I was hearing on the TV last time. There's a bunch of women who were killed. Yes, but they were just prostitutes. Oh, okay. Therefore, it is correct. The principle of thinking is the same. Oh, they're just druggies. So what does it doesn't matter. How can we get out of that rut? If you want to make me cry, all different techniques cry. The more layers we add to this, the better it is. It is as if the value of people's lives are not the same. And it's extremely sad. That reflects the mentality of people. How can we even do this? I'm not that of an optimistic in such case, but as for me, as a society, we're just driving ahead into the wall. Even if tomorrow we find all the different assets and tools, thanks to all the people around the table, all these people who act out of compassion. Jérôme is almost 50 and is very depressed. it comes back to what I was saying, is that it is really important to do sustainable human development. This, I think the language has been perfectly coined, sustainable human development. And I'm not sure if you saw recently, the Colombian president did an address to the UN last week. He provided them with a summary of all the global issues, and it started from his country. The cartel drugs destroys the Amazon, the environment, with all the different research. And we cannot fight against the drug, but we need to fight against this race for power that all the nations have. It is a race for power, and they do not care about anything else. Therefore, the concept of sustainable human development needs to be put forth. And that means we can start only by touching people and by also understanding that every single life is important. Not one life has more value than another one. All the gang, I'm so sorry. I'm sorry to bring my rock in your pond. I'm going to now pass the floor to the three, sorry, the four. We would like to send you a Zoom poll if it's okay with you. Hola, you can go. Please go ahead and launch the poll. We just have a few demographic questions. We already are going to provide you with a link. We just would like to do a little survey. What did you take? I pass the floor to Marie-Christine, Simon, then Vincent. And after that, I hope we'll have 10 or 5 minutes for the last few questions that are in the chat box. Thank you very much, Alexandra. Thank you very much, Isabel, for your testimony. The motivation and hope coming out of your speech is important. I realize that everything is politics. I'm invited as a coordinator of a medical clinic. This is one solution among many. I feel really small today. I just wanted to share with you a story about social acceptability and the education norms and what the result can be. I was a French student also in secondary school on the decriminalization of all psychoactive substances. We were said, no, you cannot do that. It's going to trigger dependencies. After debating and by showing different models like Jean-Sébastien Fallu, what he does during his presentations, that obviously if we legalize like with alcohol, there will also be repercussions on public health. So what are the different models, like with the cannabis, for example? What are the repercussions on the public health? These are much more positive. So they actually have modified their position. How come we never hear about these different models in the different medias or in the social medias? How come we, the young people, we are not invited to participate to these debates regarding legalization and decriminalization? I thought that was rather interesting to have these issues of social acceptability, educations. We cannot let go on that side. We need to take all the different tools and weapons we have to go and do a strike. It's a pleasure for me to speak after you. And I invite you, if you do not know the Global Commission on Drug Policies, Louise Arbour, Kofi Annan, they sat on it. Lots of ex-presidents or ex-prime ministers from Europe or elsewhere participated in there. There's an annual report on different topics every year. One year is a drug, and another one is the issue of perception. So it's not a drug issue, it's more a wrongful perception of drug and drug users. They used the 17 goals of sustainable development for the UN, and the realization matches every single goal or sub-goal of the UN on an economical, human, environmental plan. We may even dare to say that these are feminist positions, and I really encourage you to go and have a look at these documents, how we can fight against organized crime and gangsters or the users, how to do with small dealers. This is really an inextinguishable resource of information. Also, by doing a prohibition, they hope to reduce the consumption, but the history, they want to be convinced that consumption will not increase. I think it's more important to prove that the advantages are going to be much larger than the disadvantages. So thank you again for your share. We're talking about the increase of consumption or not. In fact, we do not care about this. You know, if people feel good in their life with substances, allowing them to be happy, I do not see where there's an issue. When they say about an increase of consumption, they're thinking that people are going to be unable to function and to be good citizens, right? But in fact, I'm not sure if I want to use the substance of my choice in the morning, whatever the conversation. I think we're going to talk about the questions because we're at this point. I wanted to add something. There are some countries where the drug war has become a druggy war, a war against users. What we can say is instrumentalization. It's like a marketing use of the addicts. We foster this fear element and we campaign about this. We just swell the data. And if there's an issue, it is because of the addicts and because of them. And if it's not because of the addicts, it's going to be because of the Jews and this and that. We need to have like a fear focus, like a projector to pipeline all the shit. And that's when we're going to say it's going to be the Arab, the Jews and the addicts, or anyways, you know, the wife or unvaxxed, whatever. It keeps going on again and again and again. Inaudible. It's my daily life. I'm just really, I feel like throwing up when I talk about this, right? Earlier, I was talking to you about my experience and my experience in Gaspésie. I was refused material when I was there, so I don't know if you imagine we're in 2022 in a CLSC. In the morning, they just told me off and they asked me to come back in the evening at 10 o'clock when it was in the morning at 9. So this is all, you know, belittling, laughing at me. This is all these little things. There's a big difference between people who are ignorant and people who really show ill will. And I have no patience with such people. This is fair enough, and it's probably correct. Sharon, I just wanted to let you know it challenges people to their own fears. This is what it does. That is it. This is very well said. We have 5 minutes left. Marie-Christine, maybe. This is a question that was in the chat box. This is a big question. In the social health models, what is the impact of safer supply on the legal products? If you would like to see the question, it is in the Q&A. The end of the question is important in the public health models. Is the consequence on the health supply considered? For example, in Europe, it increased the sale of ecstasy pills on the market. If I understand well, in fact, are we afraid that the tolerance of addicts may increase? This is a good question. In the facts, what we would have liked, and I would like that we realize this collectively, had we done this earlier, and John Sebastian talks about this often, if we had kept only like the primitive substances, if I can say so, we would not be at this level of tolerance. And when people could access to opium and coca, it was okay. It did not need to be prohibited. There was no tolerance to the point that has been described earlier. We are therefore victims to people who did not have as a focal point the public health issues. They just had this focus of profit, and this is why there's anything with the substances. I cannot provide you with an answer, beside the fact that I do not know how we can get out of it, beside having the control and the knowledge of the products that are on the market. And to let you know that the data we had prior to fentanyl and the different programs of injectable substances like heroin and hydromorphone, it showed that people do not increase their dose for life. There's just at a point people are just comfortable and they stop there. Now, for sure, there are new products on the market and it's just totally out of control and we lost control. My answer is we cannot do worse than what is happening now on the market. It is rather impossible, and though the cannabis model is pretty interesting. That means that people can actually find what fits for them by knowing exactly what they take. Oh, I know if there's a 20% THC, there's too much, I can gauge. So there's something we have not explored entirely, I think. Simon? Just for letting you know, it is very well documented that from the time of the prohibition actually incites a new flow of new products and new molecules. There's going to be a research done to find something that is not registered in the legal text that can be launched on the market without any issue. And I think it's roughly around 2010 or something, there had been a big seizure of fentanyl in Manitoba, several kilograms. And they remained free because the product was still not yet in the different annexes, legal annexes. We are near completion, 1:30. We actually responded to all the questions, so I'm really pleased. This required lots of work on our end. Thank you so much to all the people who reached out to me today, who came with us today. We have our website, so we're going to do the editing and we're going to send the video on our social medias and everything. Thank you very much to CAPUD, to the support team, the clinic, for the organization and also homelessness. Simon, thank you so much also for Solidarity of Salsa. We would like to thank everybody. Thank you also very much for the conversation. I did not have too much as a moderator. Thank you so much. We're going to close the webinar for the audience, though if the panelists would like to remain with us for a few minutes and do a debrief, I would be pleased to see you. Thank you so much. I'm going to close the recording now.